Well, thanks very much for that introduction. I have to say, despite the number of opportunities that I've had to speak and lectures that I've given, this is one of the most exciting opportunities for me and also one of the most nerve-wracking. So I have been charged with, in the next hour or so, summarizing the last 20 years of my life in a data-driven talk that also gives you a sense of my career trajectory. So in thinking about how best to do that, I decided that maybe it would be ideal to map it out for you. So I'm going to start by telling you a couple of important things about me that were true before I arrived at Arcadia. The first thing is that I love turtles. And I have loved turtles since I was about 12 or 13, when I was a big fan of the TV show Saturday Night Live. And that show featured Tippy the Turtle, who's shown here on the top left. And he was a cartoon turtle prankster who loved to go around and play practical jokes on people. And for some reason, he really caught my interest. And so I would go around the house singing the Tippy Turtle theme song, which went something like this. Hey, hey, Tippy Turtle. And so, on one of the occasions when I did this little ditty, my father noted that my profile actually was somewhat like that of a turtle. And so that started my interest in turtles. My nickname became Turtle. I started collecting turtles, both inanimate and animate. And my family humored me by spending large parts of our family vacations traipsing through creeks, looking for turtles that I could photograph and log in my little notebook. So turtles were a hobby for me, but I never really thought about them in terms of my career direction. Instead, I was pretty sure that I wanted to be an elementary education teacher and work with children who had special needs. And so I went to a local school called the Chester County Intermediate Union, where I could observe teachers in action. And just by chance, also had the opportunity to observe some physical therapy sessions with these children. And when I saw that, my mind was immediately changed, and I knew that I wanted to be a physical therapist rather than a teacher. So that's really what brought me on the road to Arcadia, which wasn't a very long road. I grew up in Oxford, Pennsylvania, only about 70 miles from here. And I came to Arcadia with the idea that I was going to pursue my degree in physical therapy after completing my undergraduate experience. So as an undergraduate, I found that Arcadia presented a world of opportunities to me, and just some of the things that I got to do while I was an undergraduate are represented here. One of the things that was really important to me was my ability to continue to participate in sports that I had been playing for a long time, and those were field hockey and softball. And that was important not only because it was a great sense of stress relief when I got out there on the field instead of being somewhere studying, but it also helped me maintain a connection to home. It was a great excuse for my parents to come and visit me by being on the sidelines. And in fact, when I spoke to Dean Vamachka a couple of months ago about coming here, that was one of the things that he remembered, was my parents being on the sidelines, and in particular, my dad shouting, "Go Turtle!" What he didn't know, and what no one except the people in my family knew, was that that was not only a cry of encouragement, but also his signal that he thought it would be a great time for me to throw a changeup. So athletics were an important part of my life outside of the classroom, and I also had many opportunities to do research in the classroom. One of those was a study that I did for my animal behavior class, where I spent several days looking at spectacled langurs in the zoo and figuring out what types of behaviors they were exhibiting. I also had a project in my psychology class where I was able to train an animal to run a maze, in this case an 8-arm radial maze. And typically one would train a rat to run this maze, but I decided to train my pet turtle, who was secretly living in my dorm room with me. I also had great opportunities in the summer. I had an opportunity to be a Pew Fellow and work at the Academy of Natural Sciences in Philadelphia. And while I was there, I studied the gills of catfishes, which was interesting, let's say. It wasn't turtles. But in an additional summer, 1 year later, I was able to travel through the Vera Hines Award to Guyana and spend about 8 weeks living in a tent on a beach working on a sea turtle project there. And so that was another fabulous experience. And throughout several years of my undergraduate career, I also had the opportunity to serve as Dean Vamachka's lab assistant. And that gave me a great behind-the-scenes look at what it really took to make a class work and to make experiments work. And it also gave me an opportunity to bring home some turtles from the lab over winter break and put them in my parents' bathtub. So I have to admit that as I reached the end of my undergraduate career, I was torn, because I was really in love with research. I loved turtles, but I knew I still wanted to do physical therapy. And so at this point, I actually applied to PhD programs in ecology with the consideration of studying turtle population biology as a career choice. And at the same time, went ahead with my applications to the physical therapy program and talked to a lot of different people, including Nima Machka and Dr. Craik, and finally decided that I did want to pursue the physical therapy career because even though I liked turtles, I liked people a lot too. So again, as I went into the physical therapy curriculum, I found another world of opportunities open for me. I loved my neuroscience course with Dr. Craik, so that was by far my favorite course. I also had the opportunity to serve as a teaching assistant in both biomechanics and anatomy, and so that was my first experience with teaching and gave me an important insight into that aspect of a potential career. And then I spent a lot of hours that are represented by these forms here as the graduate assistant for the ACCEs. And that gave me a behind-the-scenes look at just how much it took to establish relationships with clinical sites and make sure that students were able to go out on clinical affiliations that were meaningful. And I had several meaningful clinical experiences represented by the pictures in the middle here. I was able to work in Maryland, Delaware, and Virginia during my clinical affiliations. I worked in a variety of settings, including acute care, outpatient orthopedics, as well as inpatient neuro rehab. And all of those experiences were things that I enjoyed and were really invaluable to me. And then as I finished my physical therapy training, I had the opportunity to do a research project. Not unlike the projects that I heard presented yesterday, except it wasn't nearly as sophisticated, I have to say. And that project actually ended up being published as an abstract, and that was my first scientific publication. So fortunately, Dr. Craik came up with a way that I could combine those things, actually. So she convinced me to venture west and pursue the ultimate dream, which was neuroscience and turtles combined. So she introduced me to Paul Stein, who was at Washington University in St. Louis, and I went to his laboratory to begin my PhD training. So this is the first study that I did in Paul's lab. And this was a study using turtles as a model to look at how the spinal cord contributes to the control of movement. So what we did was took some turtles and we went in and did a surgical procedure where we completely transected the spinal cord and then looked at the behaviors that the turtle was still able to produce just using the spinal cord, even though it no longer had any connection to higher structures like the brain and the brainstem. And so what we found was that turtles were still able to do quite a lot with their hind limbs, and one of the things that they could do was a scratching behavior, where if we tickled their shell in a particular spot, they would reach up and actually rub against that spot in a rhythmic fashion. Another behavior that we could elicit was possible through electrical stimulation of that cut face of the spinal cord. And when we electrically stimulated, what we saw was a swimming behavior. And you can see the pattern of the movement is quite different, the purpose being to generate force against the water and propel the turtle forward. And it turns out, if we tickled the shell at the same time that we stimulated the cut face of the spinal cord, we could get the turtle to do both things at the same time in a highly coordinated fashion. So we called them, very cleverly, scratch-swim hybrids. And here's an example of that down here, where you can see the turtle reaches up and rubs against the shell, and also does the propulsive movement that would generate force to move it forward. And so on the right-hand side of this slide, what you can see are recordings that we did of the movement of the hip joint in particular, and then muscle activity. And you can see, again, in these data that there's one pattern here at the beginning, and this is the pattern for the scratch by itself. At the end, you see a very different pattern, and that's the pattern for the swim by itself. And in the middle, you see a mix of the two, indicating that the turtle was doing this scratch-swim hybrid behavior. And so from this study, we were able to conclude that the spinal cord networks controlling these movements must not be completely independent, but that there must be some overlap between the neurons controlling one behavior and neurons controlling another in order to enable the turtle to produce this highly coordinated hybrid behavior. And so that got me interested in this idea of different forms of movement or using different strategies to accomplish different things. And so I did some additional work as a doctoral student with Amy Bastian, looking at human locomotor control. And so this is one of the studies that I did with Amy. And in this study, what we wanted to know was how people walked across different inclines. So we had people just walk straight across the room in one condition, and then after that we introduced inclines to different degrees. So they had to walk across a 10, 20, or 30-degree incline. And again, we looked at the patterns of movement and muscle activity that they used in order to accomplish these tasks. And so if you look at the patterns here, you can see that there's one pattern that has this S shape, and this is a plot of ankle angle versus knee angle during the task. And then there are another group here that have more of a C shape. This indicated to us that people were using two different strategies to traverse these different surfaces. So when they were walking on a level surface or a surface with a very slight incline, they used one strategy. And when they were walking across steeper inclines, they selected a different strategy. So I was also able to perform this same study in people with cerebellar damage to look at the contribution of the cerebellum to both the selection and the coordination of these different strategies. And so as I was doing that work, I distinctly remember being in the lab one day, and Paul Stein turned to me and said, "So, have you thought about where you want to do a postdoctoral fellowship?" And I turned back to him and said, "A postdoctoral what?" I had never heard the word postdoctoral fellowship as far as I could remember, and I just assumed that once I had my PhD, I was good to go, and I was going to go out and get a faculty position and save the world. Turns out the more I heard about a postdoctoral fellowship, the more I realized it was actually a very important step in one's career, and that it was an opportunity I shouldn't miss. And so Paul introduced me to Faye Horak, who was at Oregon Health and Science University in Portland. So I made another journey, even farther west, to Portland. And while I was in Portland, I also spent some time at the University of Calgary working with Jeffrey Melville Jones. And so that collaboration between Faye, Jeffrey, and myself was all revolving around the rotating treadmill. And so the rotating treadmill is shown on the right side here. And what it is basically, for those of you old enough to remember this, a giant record player. If not, maybe a turntable or a Lazy Susan would be a good analogy. So it's basically a big disc embedded in the floor, and it spins, and we ask people to walk on it. And so I have a couple of videos to show you what that looks like. And the reason that we ask people to walk on it is because we're interested in knowing how the nervous system adapts to novel situations that are encountered. So this is a video of Mina Hong. She was the first ever PhD student in my lab, and she will live on in infamy in these videos. So on the left here, we're going to see a period of time where she is just walking in place on this rotating surface. And before my time studying this, someone decided to call that photokinetic stimulation. So what she's been asked to do is to maintain a fixed heading, so stay the direction that she started, and just keep up with the disc. So every time her foot touches the rotating surface, it rotates underneath her, and she has to pick it up and put it back in order to stay in the same spot instead of rotating around in a circle. So after someone has done this for a period of about 15 minutes, we stop the surface from moving, give them a blindfold and earplugs so that they can't use any visual or auditory information to figure out where they are in the room, and then ask them simply to just step in place, and again, to maintain a fixed heading. And so we'll see how well Mina does here. So what you'll notice is that rather than stepping in place, she's actually turning in a circle, and she's turning pretty quickly. When I say to her, "How's it going?" she says, "Fine." She has no idea she's turning. So we have done a series of studies now looking at this phenomenon of photokinetic after rotation in order to try to better understand what's going on here. What is it that the nervous system is adapting, and how is that taking place? In order to inform our understanding of how walking is controlled in general and how we can change our walking patterns to meet different demands in our daily lives. And so this is a data set from a single individual that we've trained on the treadmill for a period of 15 minutes, given them the blindfold and earplugs, and then asked them to step in place for a period of a full 30 minutes, which is shown across the bottom here. And on this axis, we have their angular velocity. So this is a measure of how quickly they were turning in space when they were stepping in place and intending to remain in one spot. And so we've done this over and over again. I've probably had 200 or 250 people on the rotating treadmill at this point. And this response is remarkably robust. I've tested maybe 2 or 3 people who don't show it. So it's really a strong phenomenon, and it's been a great tool for us to understand how the nervous system controls movement. And so what we think is happening is that when a person is training on the treadmill, their trunk is hopefully stable in space if they followed our instruction to stay facing the direction they started. And every time their foot touches that surface, it rotates relative to their trunk, creating the angle that's highlighted here in red. Then when the person is taken off of the rotating surface and placed on a regular stationary surface, their foot is now stable in space because it's on the floor, and it can no longer rotate when it's on the floor. So in order to recreate that same angle between the trunk and the foot, we think that they now rotate the trunk over the feet instead of rotating the foot under the trunk. So it's this relative rotational relationship between the trunk and the feet that we think is what's being adapted. And interestingly, it's not adapted only in the particular strategy or form of walking that the person uses while on the treadmill. It also transfers to other behaviors that they've never used while on the treadmill, and that's illustrated here. So in this particular study, we had a group of people who came in on 2 different days. Both days they trained on the treadmill and they just walked forward on it. But one day when they came off, we asked them to walk forward across the floor instead of stepping in place. And what happens is that they walk in circles. On another day, even though they had trained walking forward on the treadmill once again, when they came off the treadmill, we asked them to walk across the floor backwards. And lo and behold, same thing happens. They still turn in a circle when they're walking backwards, even though they've never walked backwards on the treadmill. And so this suggests that there's a transfer of this adaptation from the form of behavior that's actually trained on the treadmill to other types of behavior. And we've seen that this behavior will transfer not only from forward to backward walking, but from walking to running, from stepping to hopping, and even from one leg to another. So if you have somebody trained with one leg on the rotating surface and one leg on the floor, and then test the leg, it's never ever taken a single step on the treadmill, they'll still show this after rotation effect. So that's really interesting to us, and we've been trying to figure out where in the nervous system this adaptation might take place in order to influence all these different behaviors. And one of our most recent studies asked whether this could influence behaviors that aren't even locomotor at all. And so this is a study that was done by John Scott, who was an undergraduate in the laboratory. And what he did was he asked people prior to getting on the treadmill to stand with their eyes closed and point straight ahead to the wall with a laser pointer. And he measured how accurate they were on that. And this is just a stick figure representation of the group average. And you can see they were pretty good. They were able to point straight ahead prior to the training on the treadmill. He then asked people to walk on the treadmill for a period of 15 minutes. And when they finished, he again gave them the blindfold and said, okay, try it again, point straight ahead. And instead of pointing straight ahead, what you can see is that they actually pointed off to the side. And again, if you ask them how they're doing, they say, great, I've got it, I'm dead on. And they have no idea that their perception of where straight ahead is has shifted. And so this suggested to us that there is this global change. And so we've been trying to figure out where that change might be taking place within the nervous system. So one of the newest tools that we're using in our laboratory is neuroimaging, and in particular functional magnetic resonance imaging. And so what we do here is we put people in the scanner, and since we can't have them move around in order to get a good image, we ask them to imagine the movements that we're interested in instead of actually doing them. And it turns out that when you imagine doing a movement, many of the same areas of the brain light up as those that would actually turn on if you were doing the movement. So this is a way for us to get around the fact that we can't have people moving around in the scanner. And so what this figure shows is an area that was differentially active when somebody was imagining walking after training on the treadmill as compared to when they imagined walking before they had ever experienced the treadmill. So it suggests that something is going on in the cerebellum, this little area that's orange here, that wasn't there before. And so based on this and some other data, we think that the cerebellum plays a key role in this adaptive process. And so we've put together a model of how we think things might be working, and that's shown here. We think that the cerebellum is important and that it's an important area where different sources of information are integrated. So information from the inner ear, from the eyes, and from the somatosensory system, so information from the soles of your feet, for example. And that all of this information, when it's integrated, is used to inform how the spatial reference frame is adapted. And we think this, again, is a global adaptation. It's affecting more than just the behaviors that the person uses while they're on the treadmill, and in fact, affecting behaviors that aren't even locomotor at all. And so if that's happening at the level of the cerebellum, then the descending information from the cerebellum can go down into the spinal cord and influence networks for different behaviors. So this is our current idea of how things are working, and this is how I came to be interested in turning behaviors, because of this involuntary turning that's induced through the experience of walking on the rotating treadmill. And so as I reached the end of my postdoctoral studies and I had this interest in turning, it made sense to me that perhaps I should study people with Parkinson disease, because I knew that people with Parkinson disease have difficulty walking, and in particular have difficulty with turning during walking. And in fact, turning is the most common trigger of something called freezing of gait, where a person is walking and suddenly gets stuck and feels like they can't move even though they're trying to. And so as I was looking for faculty positions, one of the places that I went was back to Washington University in St. Louis, where they have a fabulous movement disorder center. And that movement disorder center treats more than 2,300 people with Parkinson's disease. So it seemed like a great idea for me to go back there. And so that's where I've been since 2004. So I'm going to tell you about a number of studies that we've done looking at people who have Parkinson's disease. But before I do that, I want to put them in context by telling you a little bit about Parkinson's disease and what it is. So Parkinson's disease is a neurodegenerative condition that affects the basal ganglia. And all of the different areas that are circled or outlined here are parts of the basal ganglia. So the basal ganglia are a collection of nuclei located deep within the brain. And in a healthy individual, those basal ganglia are all connected to one another. And so the bottom part of this diagram here shows all the different pieces of the basal ganglia. So normally there are these interconnections between the basal ganglia, and then all the information within the basal ganglia is integrated so that it comes out through one pathway that can then influence movement. And so when things are working properly, we are able to control our movement normally and efficiently. In Parkinson's disease, what we see is a degeneration of neurons in one particular structure more so than others, and that area is down here, this black area called the substantia nigra pars compacta. And the neurons in this area use dopamine as their neurotransmitter. So a person with Parkinson's disease is lacking in dopamine. And as a result, we see a disruption of the balance between the different connections of the nuclei within the basal ganglia. And there actually is an overactive output from the basal ganglia. And the basal ganglia then interfere with movement in a sense. There's too much inhibition coming from the basal ganglia, and it makes it difficult for people to move. And so the typical symptoms associated with Parkinson's disease are shown here. There are 4 cardinal signs, and those are tremor that's present at rest, bradykinesia, which is a slowness of movement, rigidity, which is kind of a stiffness and inability to turn off muscles and just allow your limb to be moved by someone else, and postural instability. And typically a person would have 3 out of these 4 things in order to be diagnosed with Parkinson's disease. But in addition to these things, there are a number of other common features that many people experience, including changes in posture, so they tend to get a more flexed and forward posture. The decrease in movement affects not only their typical movements that you might think of, like walking, but also their facial movements. So oftentimes these people are described as having a mask-like face because they have less than normal facial expression. And this reduction in motor output can also influence speech. So their speech might become quiet, fast, and somewhat monotone. So if any of you are concerned right now as you're sitting out there listening to me, I can assure you I've been tested, and as far as I know, I don't have Parkinson's disease. In addition, we see effects of this reduced motor output in things like handwriting. So people with Parkinson's disease tend to have smaller handwriting, particularly as they write for a longer period of time. And then we do see changes in gait, and we see shortening of steps and increase in cadence, and freezing that I mentioned previously. And normally, when a person gets Parkinson's disease, the onset is asymmetric. So they notice they have symptoms on one side of the body, and over time as the disease progresses, although it eventually affects both sides of the body, that side that is affected first typically remains the most affected side throughout the course of the disease. So it might not surprise you that the thing about Parkinson's that I'm particularly interested in is walking, and that really goes hand in hand with balance, because we know that problems either with walking or with balance can both contribute to falls in this population. And the problem with a fall is that when a person falls, obviously, first of all, they could injure themselves. Maybe they experience a hip fracture or some other type of injury. But in addition to that, even if they don't experience any kind of serious injury, many times the first fall can trigger a fear of falling. So whether the person is injured as a result of the fall or just fearful of falling again because they've now fallen once, they can reduce their level of physical activity. And so that reduction in activity and immobilization can then create new problems, contribute to things like osteoporosis, muscle weakness, and also social isolation, because people may not go out and participate in activities that they once did because of this fear. And all of those things can then feed into what is often called malignant Parkinson's disease, where people have a reduced quality of life and an increased mortality. So we are very interested in ways that we can better understand control of walking and balance among people with Parkinson's disease, and ways that we can better treat these problems. So the treatment of Parkinson's disease typically is in one of three areas. The first approach normally is to give people medication that tries to replace the dopamine that's been lost by the degeneration of those neurons. Another more and more common approach is the use of a surgery called deep brain stimulation, where they actually go in and implant electrodes in the brain and deliver electricity or electrical current to particular areas. And then the third is exercise. And this figure shows a search that we just did of PubMed, looking at how many studies have been published looking at each of these different types of treatment. And so the number of studies published on medication over the years, you can see, is much higher than the number of studies on deep brain stimulation. And that's not really surprising, because deep brain stimulation has only been around since the mid-90s. But what is surprising is that exercise has been around for a super long time. And the number of studies looking at the effects of exercise in Parkinson's disease is much lower than the other areas. So my lab does work in all three of these areas. In particular, I'm interested in the exercise aspect, which I think has been understudied and underappreciated to this point. So the first work that we did with Parkinson's disease did focus on turning and its relationship to freezing. As I mentioned, turning is the most common trigger of freezing. And when somebody freezes, it can be devastating to them. It's a very unpredictable phenomenon. They don't know when it's going to happen. And when it does happen, they describe it as feeling like their feet are glued to the floor. And so even though they're trying to move, their feet just won't move. And so it's problematic because it can contribute to falls. This is particularly worrisome because if turning is the thing that triggers this, that's really bad. Because falls that take place during turning are actually 8 times more likely to result in hip fracture than falls that take place when somebody's walking in a straight line. And then when you add to that the fact that people with Parkinson's disease oftentimes also have osteoporosis and are at a 3 times greater risk of hip fracture, you can see this is an enormous problem. And so it's also something that's been relatively poorly addressed thus far through the traditional treatment. So we really wanted to try to come up with a way to intervene in this area in particular, and it seemed like translating this training on the rotating treadmill into a treatment might be a possible way to go. And we thought this was reasonable because one reason that people might have difficulty with turning is that they have to change their motor pattern, they have to change the strategy that they've been using. So if they've been walking in a straight line and doing all right, and now they suddenly have to make a turn, they need to change their pattern. And there's evidence in the literature to suggest that people with Parkinson's have difficulty switching between patterns. So we thought if we can put them on this rotating treadmill as a tool to train them with their turning patterns, we might be able to facilitate that switch and make it more automatic through the use of the treadmill as an external cue. And so that's one of the first things that we tried, and I have a few videos here just to show you some examples. So this is a gentleman trying to make a 180-degree turn. So he's standing facing us, and we've asked him simply to turn and face the opposite direction. And this is prior to any experience on the treadmill. And what you'll see is that he has some difficulty over the course of the turn, and he actually freezes here. Right there, he's still trying to turn, but he's unable to keep going. And then eventually gets out of the freeze, but you can see it's definitely not safe, and we certainly are glad that we had someone there to hang on to him as he was doing that. And this is not uncommon to see. And so we asked this man to then walk on the treadmill. He walked for a total of 15 minutes, but we split it up into 5-minute chunks with 5-minute breaks in between. And so here he is, training on the rotating treadmill. This is his wife, who was cheering him on because it was somewhat difficult for him to do, and she didn't want him to give up. And so after he had walked on the treadmill for a period of 15 minutes, we then asked him to repeat the same task of turning. And so here's his turn after the training. And so what we saw in 2 people was a really dramatic difference in freezing. So people who were freezing 9 out of 10 times when they were trying to turn prior to getting on the treadmill weren't freezing at all immediately after a 15-minute session of training, and we were thrilled. And we published it as 2 case reports. And then we said, okay, let's find more people and put them on the treadmill. We realized there aren't that many people who have a lot of freezing who can still walk on the treadmill. So we said, all right, well, there are people who have turning difficulty who don't necessarily have freezing, because freezing only affects about half of the people who've had Parkinson's for more than 5 years. So let's take these people who have turning difficulty, but who don't have freezing, and put them on the treadmill. And so we did that relatively recently, and this is work that was done by Marie McNeely, who's working on her PhD in neuroscience in the lab right now. And she had 20 people come in, trained them, and nobody changed. So the moral of that story is not everything that you do in the lab works, and that even if that's the case, it's important to publish it. So she was able to get those data published to say that, you know, maybe you don't want to waste your time on this. And so that told us that we needed to look into this in more detail, because obviously this wasn't the solution that we had hoped it would be. That's not to say that there aren't some individuals who would benefit like this gentleman did. And so here's just a recording of, again, of muscle activity and the movements of the 2 heels during his turn prior to training and then his turn after. You can again just see the big difference there. So we've been looking more at turning behavior, trying to figure out what is it about turning that's different and why is it so difficult for people to do. And so what we've been measuring more recently is something called a phase coordination index. And this is a measure of a person's accuracy and their consistency in terms of the timing of their steps as they're doing a particular walking task. And what we've done is we've asked healthy individuals, people with Parkinson disease who've never experienced freezing, and people with Parkinson disease who do experience freezing to do these different tasks. And so those 3 groups are shown here. Green are the controls, red are people with Parkinson's and no freezing, and blue are people with freezing. And higher values here indicate that they have poorer coordination of gait. So a high value is bad. And what you can see is even just for plain old forward walking, there's a difference between the groups. So people who experience freezing are inherently less coordinated, even just during a simple walking task. When we asked them to turn along a very large radius circle, so walking in a big circle around the room, we didn't see that much difference in terms of coordination. We asked them to walk backwards, which is another task that's particularly difficult for them, and we see that everybody has a little bit of decline in their coordination, but that it's more pronounced for the groups with Parkinson's compared to the controls. And then we saw the biggest differences when we asked people to walk in a small circle. So something about the tight radius that they need to move in was particularly difficult. And this is also where we saw the biggest difference between people who experience freezing and people who don't. And so we think that this measure of phase coordination might be a nice objective way to quantify someone's behavior. And that's important because right now we rely on self-report. We have a questionnaire where we ask people, do you freeze? If so, how often? When you get stuck, how long does it take you to get unstuck? And things like that. And we found that that's really difficult for people to report, particularly people who have a lot of freezing, because they can't tell you how many times they freeze a day because it happens so often. So finding some other way to measure things is important here. And we've also been starting to employ neuroimaging in this area to try to figure out what is different between having to turn and walking in a straight line. And so this figure just shows differences in activity when healthy young controls are asked to imagine themselves walking forward versus imagining themselves turning. And so the areas that you see here in the orange and yellow are areas that are more active when someone is imagining turning than when they're imagining straight walking. And so we think that there's an inherent underlying difference in the motor control strategies in the different areas and how they're utilized to control turning that also might be important. And so this is work in progress, and we're just now collecting data from people with Parkinson disease with and without freezing to see if there are any differences in this activation of the brain when people who freeze imagine turning versus people who don't freeze imagining turning. We've also looked at the effects of medication on turning performance, and results from one of those studies are shown here. So what you can see on the left are trials, again, of 180-degree turning. So start facing this way, turn and face the opposite direction. From an individual with Parkinson's disease off medication, that same person on their normal Parkinson's medications, and then a control subject at the bottom. And these traces show the movement of the feet, this kind of step-like trace, as well as the head and the trunk are in here. And so if you look at the traces, you can see that they're clearly different. And it takes the person 9 steps in order to complete that 180-degree turn when they haven't taken their medicine. When they take their medicine, they're able to do it in only 7 steps, but that's still compared to a control who's able to do the same task in just 4 steps. And here are just the group data summarizing those same things. So medication significantly improves the speed at which people are able to turn, and it significantly decreases the number of steps that they require to complete the turn. But it's not enough. There's still something else that the medication is not addressing, because they're still not able to perform the task like the controls do. And in fact, when we look at people who experience freezing compared to people who don't, we see differences in their turning performance. So people who do not experience freezing are shown on the left side, and those who do experience freezing are on the right. And what we see is even when we take out trials where people froze, so if they got stuck, we threw it out. We're only analyzing trials where they're actually able to complete the whole turn without an episode of freezing. Still, even then, the people who experience freezing took about twice as long as people who don't experience freezing in order to accomplish the task. But interestingly, when we had them take their medication, we didn't see a big change in the people who didn't freeze. So their still performance off medication is very similar to their performance on medication. But the people who did experience freezing had a substantial improvement. So they cut down their turn time by a couple seconds, and they reduced their number of steps substantially. And so we're still trying to figure out, is there some difference between these groups in terms of their responsiveness to medication? Is it just the fact that the people who experienced freezing had more room for improvement to begin with? Or is it related to the fact that the people who experience freezing may also have higher doses of medication that have been prescribed to them? So again, regardless, it's still clear that the medication isn't enough and that there are remaining deficits in turning that aren't addressed. And so one of the things that we think has been overlooked in the literature, and something that we've looked at more recently in the lab, is the role of eye movement control in locomotor function. So how does a person's ability to move his eyes impact his ability to walk? And so this is the device that we utilize. And so once we've got somebody completely suited up, this is what they look like. They've got a series of reflective markers on different segments of the body where we're interested in recording their movements, and then they've got this headgear on. And so you might think, well, it's a lot of junk on them. You put all that on them and then expect them to move. Aren't you worried that you might be limiting their mobility? And we kind of were, but it turns out that we actually inspired movement in this particular individual, and the longer he had this stuff on, the more expressive he got. So this eased our concerns about this particular protocol, and we went through with it. So what I'm going to show you here are traces from an individual with Parkinson disease completing a 180-degree turn, and then a control subject. And you can see they look similar to the traces that I showed you previously, where we have the traces representing the rotations of the 2 feet, as well as the head in this case. But then there's another trace here that looks different, and that's actually a trace of the recording of eye movements that the person made as they were turning. So if you look at this, each one of these vertical upgoing segments represents a single saccade, a very rapid eye movement. So you can see this person made a lot of pretty small eye movements over the course of the turn. And it took them about 6.5 seconds and many steps to complete. Compared to the control subject, who was able to do the task more quickly with fewer steps, and along with that had many fewer eye movements. And so when we looked at these data, we were kind of surprised that there were these differences between people in the eye movements. They weren't quite what we expected to see. But again, not surprisingly, the turn performance was different. So it took people with Parkinson's longer and more steps to turn. When we looked at the eye movements, we found that not only was the number of eye movements different, but the eye movements in the people with Parkinson's disease were slower and they were smaller. And the timing of the eye movements was also different, and this was the part that really surprised us. We thought that the typical en-bloc pattern of turning that's described in the literature, where they describe people with Parkinson's disease as turning kind of like they're a log, all of the segments moving at once instead of moving sequentially from the top to the bottom. We expected to find that the eyes were going to move at the same time as the head instead of preceding the head, which is the normal pattern. But what we actually saw is that in people with Parkinson's disease, the latency between the time that they moved their eyes and the time that they then moved their head or moved their foot was longer. So there was this delay between when they initiated the turn by moving the eyes and when they were actually able to follow up by moving other segments. And so that's something that was unexpected and interesting to us. So when we put together all of this information and look at the relationships of eye movements to turning performance, we could see that eye movements were highly correlated with how long it took a person to perform a turn. So the top shows the number of saccades they made versus turn duration, the amplitude of saccades versus turn duration, the velocity versus turn duration, and then the timing of the eye movement relative to the foot versus duration. All of those were significantly correlated with their performance. We could explain 58% of the variance in turning performance. So you could predict to a large extent how a person was going to execute a particular trial of turning just based on looking at that first eye movement that they made. And so we think this is a potential area to target in rehabilitation, because if we can facilitate these eye movements and make them bigger and faster, we might be able to facilitate turning performance as well. And so that's something that we're interested in looking at. Another direction that we've taken with this work is looking at the effects of deep brain stimulation. And so here's just a diagram showing the particular type of surgery that's done at Washington University. And it is implantation into the subthalamic nucleus. And this is one of the structures that I told you earlier as part of the basal ganglia. So in this surgical procedure, there are electrodes implanted, typically bilaterally, one on each side of the brain, and they look like this. And they go and they drill a hole in the skull, put these electrodes in, snake a little wire from the electrode down to a pacemaker, essentially, located below the collarbone. And then that pacemaker is a stimulator that can be adjusted. So you can turn the voltage up or down, you can turn it on or off. And so that's what we were interested in looking at, was how does this stimulation impact turning performance and eye movements. And so this is, again, something that we're in the process of doing. This is pretty new data. And this is just from a single person in 4 different conditions. So we tested them with their stimulators off and having not taken medication here. And you can see it took them about 6 seconds to complete the turn, and a lot of steps and a lot of eye movements, as compared to this lower right-hand side where they've taken their medication and their stimulators are turned on. So that's where we see the most benefit, but it's actually not much different from just turning the stimulators on when they don't take their medicine. So it seems like this deep brain stimulation is doing the most to help with the eye movements and turning performance. And medication can also help on its own, but when you add the two together, there's not much of a combined effect here. And so that's something we're continuing to pursue. Another study of deep brain stimulation that we've done recently looked at whether it matters where within the subthalamic nucleus this electrode is placed. So the subthalamic nucleus is a pretty small structure, and it's kind of hard to get the electrode in the right spot to begin with. So we're just generally happy if it gets in there. But the nice thing about the electrode is that it actually has 4 different sites that are active contact points. And you can program it. So you can turn on one of these sites and stimulate in that spot, or you can turn on a completely different site. And so with a single electrode, we can differentially stimulate either the dorsal or the ventral portion of the nucleus. And this was of interest to us because there are a fair amount of anatomical and physiological data to suggest that there are distinct regions within the subthalamic nucleus, and that the dorsal region is more associated with limb movements and motor function, whereas the ventral region is more associated with cognitive function. And so our prediction was that people who see the most motor benefit from the surgery are going to be the people who have dorsal position of this electrode compared to ventral. And so we wanted to see if that is indeed the case, and to try to better understand the mechanisms by which deep brain stimulation works, because we know it works, but we still don't understand how it works. So in this particular study, we had individuals who had an electrode that was positioned similarly to this, where they did have a contact in the dorsal region and another in the ventral region. And so we had them do a series of tasks with the stimulator turned completely off, or with the dorsal contact active, or with the ventral contact active. And so when we looked at gait, whether we looked at gait velocity or stride length, whether we had them walk as fast as they could or at their preferred pace, we saw similar things, and that was that their gait performance was better when the stimulators were turned on, regardless of whether they were stimulated in the dorsal or the ventral part of the nucleus. And so that you can see that across the board here. So it didn't seem to matter in terms of gait where the electrode was located. We also looked at their motor symptoms, and we used something called the Unified Parkinson Disease Rating Scale as a rating of overall disease severity. And again, we saw improvements in that. Lower scores indicate less severe motor symptoms. So their UPDRS scores improved when we turned the stimulators on. But again, it didn't matter whether it was dorsal or ventral stimulation location. And then we also looked at balance, and we used something called the mini-BEST test, which is a relatively recently developed balance test. And what we saw was, despite the fact that we're seeing improvement in overall motor symptoms and improvements in walking, the balance is relatively unresponsive. And that's something that's been true also looking at the effects of medication. So there seems to be something resistant about balance. And so balance is something that we're particularly interested in, and we think it's important because we need to be able to measure it effectively in order to identify who might be at risk for falling and then be able to intervene appropriately. And so I'm going to tell you about a couple of studies where we focused on issues of measurement and looking at how well we can predict balance function using different tools and be able to identify who's a faller and who's not. So our first work in this area was done by Abby Letty, and she was a DPT student who did a research fellowship in the lab. And so she had a group of about 80 people with Parkinson's disease come in, and they did 3 different balance tests. They did the Berg, which is the gold standard. They did the functional gait assessment and the BEST test, which is a relatively new test. And so the distribution of scores for the 3 tests is shown here. At the top is the Berg, and this is the reason why we were interested in finding things to replace the gold standard, perhaps, is shown here, and that is that lots and lots of people in our sample scored at the upper end, so there was a ceiling effect. And that says that even though a lot of these people we know are having difficulties with balance, and some of the people who scored a perfect score are falling. So there's something, some limitation to this test, as compared to these others where you see more of a normal distribution and less of that ceiling effect. So we use something called receiver-operator characteristic curves, and one of those is shown here, to look at how good these tests are at correctly picking out who had fallen in the last 6 months, but also not incorrectly identifying people who hadn't fallen as fallers. And so a perfect test would score right up here, and just guessing, you have a 50-50 shot, would be along this line here. And so what you can see is that the tests were fairly similar, although the best test was indeed the best test. So the developer of that test has named it well. So among the tests, this one was a little bit better at picking out who had fallen and who hadn't in the past 6 months. So that's all well and good, but you know, it's easy to figure out who's fallen in the past 6 months. Just ask them, right? You don't need a balance test. So what we wanted to know was, well, if we take these same tests and now look at people prospectively, can we predict who's going to fall in the future instead of being able to identify who's already fallen in the past? And we also wanted to know, does it matter which of these tests we use in order to try to make that prediction? And so this is work that's been done by Ryan Duncan, who is a research physical therapist in the lab. And so we looked at those same types of data at 6 months and at 12 months. So the same sample of 80 people, we evaluated them and followed them for a whole year and looked at who fell in the first 6 months and who fell over the 12-month period. And so the curve here doesn't look all that different from what I showed you. We're getting some pretty good results. Again, the best test seems to be the best test at identifying who was going to fall over the next 6-month period. And the mini best test was also fairly good. And the mini best test is a condensed version of the best test that's made to be clinically friendly because it doesn't take as long to administer. But when we look at the 12-month data, we can see those lines are sinking and they're falling back down toward the line that's, you know, you got a 50-50 shot, flip a coin and decide if they're going to fall or not. And so what these data tell us is that although we're pretty good at predicting who's going to fall in the next 6 months, we're not so good at figuring out who's going to fall over the next year. And I think that speaks to a need for a change in the model of physical therapy that we currently use for people with Parkinson's disease. And so that model is basically a model of underutilization, in my opinion. A lot of people who have Parkinson's disease never are referred to see a physical therapist. And when they are, they come to us after they've already had multiple falls or other problems. And I think what we would be better served by is something more like a dental model of care, where we see people every 6 months for prophylactic care. We can evaluate their balance and all other aspects of their health, give them recommendations, and see them again in 6 months, and hopefully head some of these problems off at the pass rather than having to deal with them when they're already in place. And so I think that we can play a role not only in providing physical therapy services within the clinic, but also in helping to guide these people towards increasing their levels of physical activity. And physical inactivity is a huge problem among people with Parkinson's disease, and we know from recent work that people with Parkinson's disease are about 1/3 less active than their peers who do not have Parkinson's disease. And this is a problem for several reasons. There's evidence to suggest that a sedentary lifestyle and lack of physical activity might actually worsen the motor features associated with Parkinson's disease and also worsen non-motor features, which I haven't mentioned yet, but can be equally problematic. There was also some work in Italy where they took a group of people who had congestive heart failure and randomly assigned them to either take waltz classes or walk on a treadmill as part of their treatment. And lo and behold, the people who walked on the treadmill didn't really like it. Whereas the people who were waltzing said, man, my quality of life is going through the roof. This is great. And when you looked at their cardiovascular benefits, equivalent between the two groups. So why not do something that provides the most bang for your buck, that gets you the health improvements that you want, as well as the enjoyment? And so we were inspired by that, and also by an abstract that we saw presented back in 2005 that really was the direct trigger for this work. This was work from Patricia McKinley from McGill University, and she had a study where she took frail elders who were at risk for falling for various reasons and assigned them to either tango dancing or walking in the community. And once again, tango came out as the winner. The people who danced the tango showed greater improvements in their walking and also some improvements in cognitive function in that study. And so after talking to her at that meeting, I came back to the lab and suggested to Madeline Hackney, who was a professional dancer who had come back to graduate school and happened to be in my lab, that maybe we should try this. And so that's what we did, and it snowballed from there. We've done a number of different studies now, looking at tango as an intervention for people with Parkinson disease. And so I'm just going to tell you about the most recent of those studies. So we think that tango is a reasonable approach because it might target specific motor impairments that people with Parkinson disease experience. So for example, people with PD have difficulty with backward movement. When they fall, they oftentimes fall in the backward direction. And if you're dancing tango and you're in the follower role, which is the traditional female role, you are walking backwards pretty much the whole time. So within the context of the dance, you learn a specific strategy for moving backwards safely. But you don't realize that you're learning it. All you know is that you're dancing and having a good time. So we also think that other aspects of the dance, like the fact that there's music and a partner, might be particularly useful because they can serve as external cues to help facilitate movement in the person with Parkinson disease. And finally, it's a socially engaging activity. It motivates people to want to continue to participate, and it's something that caregivers get as much out of as the participants with Parkinson disease. And that's something that we've heard reported anecdotally again and again from our participants is this is great because it's something that we can do together. So our most recent study was looking at both the short and the long-term effects of tango dancing for people with Parkinson disease. We had our participants come in and we evaluated them at baseline and then randomly assigned them to either a tango class or a control group that did no exercise. And the people came in and danced for an entire year for 1 hour, 2 times per week. So we looked at their performance at baseline and again at 3 months, 6 months, and 12 months because we wanted to get a true sense of what is their current disease state without the potential masking of symptoms as a result of the medications that they're taking. We always partner the person with Parkinson disease with an individual who does not have Parkinson disease for reasons of safety. And we make everybody dance both roles. So just because you're the man doesn't mean you need to lead all the time in our classes. In fact, you're not allowed to. And you're also not allowed to dance with this person that you came with the whole time. We think that might facilitate learning because you have to kind of relearn how to do it with the next person down the line. So about every 10 or 15 minutes, we have people change partners. So I'm just going to show you the course of the study. So we had 123 people that we screened. We ended up with 62 people that we randomized to groups. And the data that I'm going to show you come from 52 people who we were able to collect data from at the end of the 1 year period. I'm going to show you just 3 graphs that look like this. And these are basically showing the performance of the 2 groups, tango shown with the filled black dots and the control shown with the open white dots here, at baseline, 3 months, 6 months, and 12 months. And this particular figure shows their walking velocity when they were asked to dual task. So we asked them to walk and name as many words as they could think of that began with a particular letter while they were walking. And what we saw was that at the beginning of the study, there were no differences between groups, but over the course of the study, the people who participated in tango increased their walking velocity, while the people who were in the control group didn't change much. And we did measure their performance on the cognitive task, and it wasn't that they were just not answering us. They were still giving us correct answers at the same rate, and they were actually able to still improve their walking velocity. And we also found improvements in standard walking tasks that didn't involve a secondary cognitive task. But we think this is perhaps even more important in terms of real-world applications. We also looked at balance, again, using the mini-best test. And what we found was, again, an improvement in the tango group over the course of the study. And there seemed to be cumulative benefits. So although the most gain came in the initial 3 months, people continued to participate, they had still an upward going trajectory over time. and the controls in this case got maybe a little bit worse. So we don't know yet, because this is a new test, what the minimal clinically important difference is for this. We do know that a cutoff score of 20 is what we would use to consider someone at risk for falling or not. So in this case, the Tango and the control groups are starting out below that cutoff, so we would be worried that these people are potentially at risk. But after the 3-month time point and beyond, the Tango group has now moved to a point where we wouldn't be as concerned about their risk of falls. And then finally, I think what's the most exciting is that we actually saw changes in our measure of disease severity, which was this unified Parkinson Disease rating scale. And so this scale takes into account a variety of things. It measures tremor, it measures rigidity, postural instability and gait. It measures hand movements, foot movements, speech, facial expression, you name it. It's a really comprehensive overview of how severe their motor symptoms are. And higher scores, again, indicate more severe disease. So what we see over the course of the study is the control group holds relatively steady, while the Tango group shows substantial improvements. And on this scale, a change of 3 points is a minimal clinically important difference, and a change of 10 points is considered to be a large and clinically important difference. And so we saw a change of the 10 points in the 6 month, at the 6-month time period. So this suggests us that we may actually be changing the progression of the course of the disease here, at least in the motor symptoms and also perhaps the disability. And so, to our knowledge, this is one of the first studies to demonstrate that with exercise, and so we're pretty excited about that, and certainly want to pursue this work further. And we think that by introducing physical activity, such as the Tango, we can actually break the cycle that's shown here. So we can reduce the negative impact of that sedentary lifestyle on the motor and non-motor symptoms. We can also potentially reduce the other sequelae associated with physical inactivity, and hopefully ultimately reduce mortality associated with Parkinson's disease. But I don't want to leave you with the impression that Tango is the end-all and be-all, because there are other forms of physical activity. And in fact, some people don't want to do the Tango, as is nicely illustrated here. So in our future research, we are interested in looking at not only Tango, but other interventions, including treadmill training. And our current plans are to do a head-to-head comparison of Tango to treadmill training, where we also implement our neuroimaging techniques to do a before and after study and see whether these interventions impact not only physical performance and motor symptoms, but actually the activity and connectivity within the brain. We're also interested in using those same tools to explore the mechanisms underlying things like freezing of gait. We will continue to design and test novel treatment approaches. One of the things we're thinking about is looking at using deep brain stimulation asymmetrically. So since the disease is inherently asymmetric, it makes sense that maybe you would want to stimulate in an asymmetric way in order to try to make people more symmetrical. And so that's something that we're exploring right now. We're also exploring some other forms of dance, including a form of modern dance called Contact Improvisation, and looking at different cueing paradigms, including cues to help facilitate eye movements in order to enhance locomotor performance. And finally, we're interested in developing and testing new and better outcome measures to assess balance and gait. So I think you can hear from this that in the lab we're pretty busy with research, and I see some worried looks out there and saying, well, what happened to the turtles? I want you to rest assured that I do find ways to work turtles into my life, although not necessarily in the lab. And I have been known to show up at 1 or 2 Halloween parties dressed as a turtle. And I noticed as I was walking through the Carlin wing today that some of the graduating class also has dressed as turtles at Halloween. I thought, yeah. So we wear these costumes as a family to the Halloween parties that are hosted by the DPT students. And so I just want to mention the fact that students are an important part of what I do, and that I do enjoy the teaching and mentoring that I'm able to do. I get to work with undergraduates, graduate students in the DPT and PhD programs, postdoctoral fellows, and junior faculty. And in working with all of these people, I try to remember the lessons that I learned by observing the faculty members that I had here and the mentors that I had here at Arcadia. And so I try to challenge people by providing them with opportunities, but also giving them the resources and guidance that they need in order to be able to take advantage of those opportunities. I try to remember to keep their best interests in heart instead of what needs to get done in the lab. I try to be generous and available with my time and to have fun while doing all of this. And I definitely do enjoy what I do. And I have been known to try to make it even more fun by dancing or singing in the classroom. And I do that because I learned here from Dr. Bluestein, who one day in psychology brought his guitar and sang us a song about neurons and synapses, that things that are delivered through song or dance are things that are remembered. And so I appreciate that lesson from him. And so I'm very fortunate to be where I am. I'm surrounded by great people. I've shown you the work of many different people from the lab today, and they're pictured here. So people whose names are in italics are people whose work I've shown you, and their pictures are also there. I didn't have room to show everybody. But without these people, this work would not be possible. And it also wouldn't be possible without the different sources of funding support that I've had throughout the year. So I'm grateful for all of that. And there are also some people in particular that I'm grateful to. So what I've shown you today is the path that I've taken. And I'd like to just finish by acknowledging some of the people who've been really important along that path. The first people being my parents, Chet and Ruth Earhart. They have always been on the sidelines supporting me. And you might not realize it because you didn't hear any cries of "Go Turtle," but they are in the room today. And so I thank them. I'm also particularly grateful to Dean Vamachka and Dr. Craik for the exceptional education they gave me in the classroom, the mentoring that they provided outside of the classroom, and really showing me how I could combine my interest in research with my love of physical therapy, and even work a turtle or two into the mix. And so it was Dr. Craik who introduced me to Paul Stein, who was a fabulous mentor during my doctoral years in St. Louis, along with Amy Bastian, and they really gave me the foundation of basic science skills that I needed in order to move forward. There was another Paul in St. Louis who turned out to be pretty important. He's a fellow graduate student at WashU, and he decided to follow me to Portland when I went to do my postdoc, and he's now my husband of almost 10 years. And then in Portland, I had a great experience too, working with Faye Horak and also Jeffrey Melville Jones. Really, two very experienced mentors who gave me a lot of insight into the importance of collaboration and the ability to do things across international lines. And also, the best thing that happened in Oregon was that Paul and I had our son, Malin. And when he was about 3 months old, we packed up and moved back to St. Louis, where we've been ever since. So I feel really blessed to be where I am, very happy in what I'm doing, very grateful to all of these people and many more who I unfortunately couldn't name today, and really grateful to have this opportunity to be here today. I greatly appreciate the many wonderful opportunities that I had during my years at Arcadia, and I feel very fortunate and proud to be a graduate of this institution. Thank you. I'd be happy to try to answer them.
I really was interested looking at one of your graphs on, I think it was a measure of coordination with different tasks. I think it was forward walking, backward walking, and turning in circles. Just clinically what I've seen, I didn't know if you had other data looking at like comfortable pace walking versus fast walking, and then if the coordination changes.
That's a great question. So what he asked was whether we have data similar to the data that I showed about the coordination of walking during different tasks. So I showed you forward and backward walking as well as turning in a small radius and a large radius circle. And so Scott wanted to know whether we also have data about preferred pace versus fast gait, and that's actually something we're doing right now. So April Williams is another DPT student in the lab, and she's got some really interesting data where what we were trying to do was independently manipulate cadence or step length and keep the other one fixed, because so far everything in the literature lets them both vary together. And so what we see is that when we increase cadence and make people take steps at a really fast rate, their coordination doesn't get much worse. But when we ask them to take really small steps, that's what does it. So it seems to be that the shortening of the step is associated with the poorer coordination. And then when we combine the two and ask them to take really small steps that are also fast, it's pretty comparable to the small condition. It's not much worse. So it seems to us that this regulation of the amplitude of the steps might be the key rather than the speed.
So with that, do you see improvement when they take large, fast steps?
So that's a great question. question too. So maybe could we have them take large, fast steps and see some sort of improvement? And that's a good idea. I'll tell April. We haven't looked at that yet. But yeah, and that's something that we do clinically. You know, we give people visual cues or attentional cues to take big steps. Maybe we are enhancing coordination through that mechanism. We can just find a way to make that stick, then we'll be in business.
What kind of person taught the dance class?
So the question, what kind of person taught the dance class? So originally they were taught by Madeline Hackney, who had a background in professional dance and then was working on her PhD at the time, and so has some knowledge of Parkinson's from being in the lab. She has since moved on and is now a postdoc at Emory University, so we've had to find additional teachers. We've had a DPT who had a background in ballet and also knew some tango, teach it for a while, and then she decided to move. So now we have some people who didn't know anything about Parkinson's and knew a lot about tango and were willing to learn about Parkinson's. And so we've worked together to educate each other. And so I think it's important that it be someone who knows something about geriatrics at a minimum and Parkinson's disease preferably, because they're not your typical run-of-the-mill tango classes. We show the moves as they're intended to be done, and then we show variations on the theme. So if you can't cross your feet completely, you could put one in front of the other, or you could just put them right next to each other, and you do what feels comfortable for you, and when that becomes easy, then move on and make it more difficult. So I think that it needs to be somebody who knows how to modify things.
And then how did you add contact improvisation?
So how did we add contact improvisation? That was actually something suggested by David Marchant, who's one of my colleagues in the Performing Arts Department. He had read about our tango work, and so he popped over and sat in on one of our tango classes, and then we sat down at lunch, and he said, you know what you should try? Contact improvisation. And it was like the same moments as his postdoctoral fellowship. What? I'd never heard of it, didn't even know what it was. And so for those of you who don't know, contact improvisation is a form of modern dance where basically you have a partner and you have to maintain some point of physical contact with that partner, but it can be a rolling point. So you might start out hand to hand and end up back to back, or knee to shoulder, or anything. It can move from the floor to your partner lifting you in the air. It's very dynamic. And so the nice thing about it is it's unpredictable. So your balance is constantly being perturbed by your partner. You have to respond to that. And so it seemed like a good idea, and so we did try it. And the people who participated in it really liked it. And one of the reasons they liked it was because they didn't have to learn any particular step. They could dive right in. And also people who had a lot of dyskinesia, which is kind of the unwanted movement that's a side effect of medication that Michael J. Fox often has when you see him on TV, found that they could just weave that dyskinesia into the dance, and it became part of what they were doing. Okay, thanks very much.